Okay, welcome everyone. Thank you so much for being here. This is our CPE related to reducing weight stigma in healthcare and dietetics, a socio-ecological approach. We'll be here until about 2:15 Mountain Time, and let's get started. Emily, are you seeing people in the waiting room that you can admit?
No, I'm not seeing anybody.
Okay, then I will try to admit everyone really quickly as we keep going. Okay. All right, everyone. So our disclosures for today, it's requested that we share this disclosure from the Academy, which basically states that we are not the Academy is not responsible for what we, the provider, are interpreting as far as the Code of Ethics goes. And then in terms of conflicts of interest, myself nor the presenters presenting today have any conflicts of interest to disclose. Before diving into content, we've got a couple of pieces of information to share. Please use the chat to ask questions or introduce yourself. At the end of each section of the presentation, we will be allowing time for questions and comments. And so we encourage you to unmute yourself and share that way, but you can always use the chat as well. Otherwise, we ask that you stay muted in order to limit the background noise, and we'll try to make sure everyone is muted as well. Today, we are delighted to be able to offer 2 CPEUs for those attending live and for today's full session. CDR requires that RDNs obtain 1 CPEU related to ethics or health equity, and today's CPE will cover that. We'll provide you with a certificate to keep on record in the event that you are audited. And we're also recording attendance. If you feel comfortable sharing in the chat who you are, where you're coming from, whether that's a facility, a university, or just the geographical location where you're located, and whether or not you're a preceptor at UNC. That way we can all kind of get to know each other in the background here. If you don't feel comfortable sharing with the group, that's completely fine. We just wanted to make this more of a collaboration rather than just simply a presentation. So we are delivering CPEU certs. You can email me directly or you can email Taylor, who is our GA who's going to be supporting us here. And as a reminder, this CPE is currently being recorded. We want everyone to feel comfortable speaking up and sharing their experience, but recognize if you don't want to be publicly displayed. So if you have something to say, we encourage you to say it. And then if for whatever reason you decide, never mind, I don't want to be on the recording, let me know and I'll do my best to edit your portion out. So for those of you watching this recording, if there's a choppy cut somewhere, that might be why. Okay, so our agenda today, the reason we're all here, we're going to start with some introductions, and after that, we're going to move forward with our topic, which is reducing weight stigma, a very relevant conversation in healthcare, education, and particularly in dietetics. And then we'll address some updates pertaining to dietetics education and UNC programs specifically. Director Boldrin will share some updates pertaining to Ascend and implementing the standards that will be rolled out in 2027, and we'll discuss some updates that pertain to UNC specifically. Okay, so I'm going to take a moment to share about our presenters. So for those of you who don't know me, my name is Brianna Bach, formerly Williams. Pronouns are she, her, and I've been the program coordinator here since 2022. My main functions are related to preceptor support, so don't ever hesitate to email me if you have questions. We can set up a meeting. Really, I'm here to support you. So, and I always want to know what's going on in your lives and in your professions. Over the past 4 years, I have been coordinating the DI and the MSDI. I also just finished my master's here in exercise science, which was a wonderful opportunity to do here at UNC with my colleagues. Prior to this, I began my career at the Johns Hopkins Hospital. I think I saw my former CNM here. Hi, Linda, if you're listening. I was primarily inpatient, but I also performed some outpatient functions, and my specialty was critical care ultimately, with EN and PN being my passions. Our director is here, Dr. Emily Boldrin, who'll be speaking later in the session. We are so grateful to have Emily. She has had such a long career in academia, both teaching and directing. We were so grateful when Emily took over the role in 2025 as DI and MSDI director. Prior to this, Emily has been working in higher ed since 2003, specifically with distance programs since 2009. So Emily has extensive experience that we've been so fortunate to draw upon. And I'm delighted to introduce our speakers for the weight stigma in healthcare and dietetics presentation, starting with Rebecca Romine. Becca has worked at UNC since 2013 in various roles, and she's delivered this presentation or a similar presentation to UNC at a university-wide professional development day a couple of years ago that I attended. And ever since, I've been working with Becca to try to get her in to present with us. She is a very, very busy lady, so we're so grateful that she's here. We also have Lisa and Nick. Lisa Caldwell and Dr. Nick Slagle are dietitians and dietetics faculty members who teach, perform research, advise students, and everything in between. Lisa began teaching at UNC in 2016 and assumed the DPD director role in 2022. Prior to this, Lisa was a WIC dietitian and supervisor with themes of pregnancy and lactation permeating her research, along with topics spanning from education to impacts of alcohol use. So quite a wide variety with Lisa. And Dr. Slagle joined our team in 2021 with some notable course teachings and research pertaining to sports performance, specifically in estimating energy needs for climbers, and has researched nutrition education across the socioeconomic spectrum. So I will ask our presenters now to take it away. Becca, thank you for being here.
Can you hear me okay? Perfect. All right. Brianna, thank you so much for that introduction. So I'm here mostly just as a subject matter expert. The things that I'm going to cover in my presentation today, why this is important, why are we talking about this today? Also, there are some ground rules that I want to set specifically for this presentation. And then sprinkled throughout all of this, you're going to hear my story. And then also some things that I've heard from other people who have shared it. So these are all like firsthand accounts. This isn't like something I picked out of a book from 7 years ago necessarily. This is all, stuff that happens. So the ground rules that I would like to set. Let's see here. So first of all, you may hear some things that are going to be triggering today. And I apologize about that. It's just kind of the nature of the beast, unfortunately. Maybe consider, having something on which to write for your observations, for your feelings, your feedback or whatever, because I would like to hear it at the end. I recognize that body size is a spectrum. It's not just, you're slim or you're overweight. There's a whole spectrum of folks in between there. And I am also going to be speaking about my experiences and experiences that I have heard directly about. I also want to be clear that I'm not speaking about body stature. So when I say big, I don't mean someone is tall. I mean that they are of a larger body. And then again, you will probably have reactions. That's one of the things that that you can use the paper for. And again, I do want to know your feedback. I know that Brianna has shared her email as well, but if you have things that you would like to specifically share with me, feel free. My email is right there. All right. So why should you listen to me? Why do I consider myself a subject matter expert on this? Well, I know a thing or two about living in a larger body. It is my most salient identity. If you saw me walking ahead of you in a snowstorm, and all you saw of me was my winter coat and, You couldn't really tell my gender. You couldn't tell my race. You couldn't tell anything else. You just saw me walking ahead of you in a winter coat. You could immediately tell, like, hey, that person is of a larger body. So I think I know a thing or two about it. And as you saw there were photos sprinkled from throughout my life, from my 8th grade graduation to my wedding to when I was pregnant. And then obviously my kiddo, who's actually going to be 3 on Sunday. So she's not that little anymore, but she's still pretty little. So why should you care? Why should you care about this at all? Body size is not recognized on many sites as an identity because most people think it's something that can still be changed. And about 10 years ago, the obesity rate in America was around 37%. We are currently at 42.4%. And projections for population from now, in about 4 years, this is going to be about 51%. So that is a large chunk of the population that's going to be classified as medically obese. And there is an identity disparity going on amongst folks who are classified as obese. And for those of us at UNC specifically, and for other Hispanic serving institutions, it's going to be impacting a lot of people that we interact with, a lot of our students. When I very first gave this presentation, the university that I was working for, which was not UNC at the time, did not list anything about physical appearance on their DEI statement, which I found interesting because they were one of the ones in the area that I was teaching or working in, I should say, that people kind of looked up to as a diversity leader, and they just kind of did not have it. But I am proud to say that UNC had this on their website, but it only mentions physical appearance. It's a broad category, and I am happy it's there, even though it doesn't specifically mention anything else. It just says physical appearance. Okay, so I think the best way to walk you through kind of what it's like to live as a person of size is to take you through a day in the life of me. So this might be a little weird of a concept for you all, but let's pretend that it's NHS launch day. And for those of you who don't know what that is, our college every fall has a sort of like kickoff to the semester where, our dean gets together and presents on the things that have happened over the last year, helps us all kind of navigate the ground and prepare for the year coming ahead and all of that. So let's just pretend to be me going through this typical NHS launch day. To set the scene a little bit, it's usually the week right before classes start. So it's move-in week. So that's already going to complicate things anyway. And let's just figure out some of the problematic things that a person of size can experience. The very first thing, parking lots. This is an actual photo from one of our UNC parking lots on move-in day. And, if someone parks a little too close to one of those white lines, whether, the person next to them was being a jerk or they're just, in a hurry to find a spot, I may not be able to get out of my door. Or I may not be able to get out of my door without dinging someone. So parking lots can be a problem. I mean, here we are, we're restarting the day and we have a problem, right? So something else you should know about Becca, her back hurts. So the next thing that we're going to do when we go into the building is we have to decide if we're going to take the elevator or the stairs. Sorry, I skipped ahead there one. And that in and of itself can cause some issues, right? Even the decision in and of itself, if somebody sees you like taking the stairs, let me say me as a person of size has this running narrative in the back of my head. Yes, I probably should take the stairs. It's healthier for me. Or I would be afraid of what other people would say. Like, hey, that's why you're so fat. You should take the stairs. Never mind that your back hurts. Never mind whatever. Like, you should be taking the stairs, right? Something else that's a problem about elevators that some people may not recognize or realize, when you step onto an elevator, there is a weight sensor that can go off. You step into an elevator, you look up, it's kind of above all of the floor buttons that you can choose from. And it's like weight capacity, 2,500 pounds or 1,500 pounds or whatever it is for that particular elevator. So if you step onto the elevator and there's already people on there, or maybe there's facilities is moving up a desk to a faculty office, right? And you're kind of mentally doing the math about, okay, how much does all of this weigh together? And if I stepping in there, am I going to set off the alarm to this elevator? Is it going to be super embarrassing? Am I going to have to step off and like, just be embarrassed? Am I going to have to wait? So taking the elevator in and of itself, and then also figuring out, what's on there, who's on there, how much they weigh, is just kind of something that we encounter a lot, or that I encounter a lot. Another issue that we run into as folks of size are the desks. So these are the actual desks in each of our buildings. That one there on the left that says 1060, that one is the actual classroom where we start the NHS launch day. And as you can see, it's those wonderful desks that I'm sure we all just love so much, that they can kind of pick up and lay down. And so as a person of size, those are not great because oftentimes they don't sit down flat on my tummy. They're kind of slanted a little bit. And so this is the room where we have our breakfast, which is not great in and of itself, because I mean the desks don't even sit there, and then you want me to also have food, right? So that's fun. But then the other slide there on the one on the right is just another example from our building. Just, it's not just the one building that we have, it's the other one as well. Let's see here. So then it's breakfast time, and maybe Becca's found a place to sit. Maybe she's balancing all of these things, or she's willing to balance all of these things. And then we get to the food, which folks in attendance who have been to the launch day, or who may be familiar with catering on college campuses, this is typically what we have catered for our breakfast. It's bagels with cream cheese and fruit. I see protein there in the form of cream cheese, and that's questionably protein, right? Like, yes, it's got protein in it, but there's also a lot of carbs, there's flavors in it, there's all kinds of stuff, right? And then it's also just very, very sweet things. Which, fun fact, I also have diabetes, so this may not be the best thing for me to be eating for breakfast, but it's what's provided. And it was launch day, it was a hectic day, and I didn't have time to grab anything else, so I guess I'll just have some of this food, right? All right. So then after breakfast, we move into another area, which is a little more friendly. I can definitely, sit in these chairs more comfortably. But where am I going to sit? Do I want to sit in the middle and be that person on the airplane who needs to sneak by everybody like, sorry, I got to the bathroom, I'm sorry? Or do I want to like be the person on the end who's kind of also that person on the airplane, like, oh, you need out. Okay, let me get out. Oh, you need out. Let me get out. Where do you sit? And it's just kind of an interesting quandary that I face when it comes time for this kind of thing. Okay, so we made it through launch day, which is usually only a half a day meeting, and now it's proper lunchtime, and Becca needs to go buy some clothes because, well, new semester, let's get things started. Let's go see what we can find. Oh, I like this dress. That's pretty. Yeah, I can make that work. Wait a minute. Why does my size cost $5 more than my friend's size, who's like one size less than me? Does it take $5 more of fabric and material to make my dress than hers? Okay, whatever. Okay, well, I bought my dress. That's fine. Now I also need to get a ladder because we're moving into a new place. So let's see here. I really like this one. Okay, yeah, that could work. I could totally make that work. Oh, look at that weight capacity. So even if I were able to stand on the ladder safely, could I carry up my paint or my heavy picture or name your price, right? Could I carry it up there safely and not run the risk of having the ladder collapse under me? Something to think about. Okay. Oops, I think we froze. Sorry, Elle. There we go. Oh my gosh. All right. Bathrooms. Yep, bathrooms. And this is the typical view of a woman's stall here in the building that I'm in called Gunter Hall. It's not very wide. Sometimes folks who are of a larger size, like myself, have a hard time doing what we need to do in this bathroom safely, efficiently, effectively. So we're often stuck between, well, do we take up one of the, disabled stalls, or do we use one of these and potentially not do everything we need to do? So, all right. Made it through the workday. Everything's fine. Now I'm going to go meet my friends for dinner after work. So we're going to a restaurant. Here's an actual a photo of me with some of my high school friends at a restaurant. I don't even remember which one this is, honestly. It looks like maybe Red Robin. I don't know. But just the seating choices are interesting. I'm either relegated to sitting at a table comfortably or squeezing into a booth comfortably. And then, that carries with it, restaurants carry with it a whole other stigma of like, what are you eating? And all of the choices and all of that wonderful things as well. So, okay. Whew, it's been a long day for Becca already, but she's still got to go to the grocery store and get some lunch options for work. Let's see what we've got here. So if someone could please just keep a running total on these, I'm going to have some options that are more healthy and some that are more questionably healthy, just to see, what's going on. Because remember, Becca has a 3-year-old now, so we need to, have money left over for other things. It's not just, not just me and my husband that we're buying for anymore. And, right now I'm the only one working in my household. So again, money's a little tight. So let's figure out what Becca can get for lunch that would keep her nourished and keep a little bit of money in her bank account. Okay, salad. Yeah, that's a good choice. So I usually go for the 50-50 blend there on the bottom. So that's $5.99. And then we need some dressing to go with it. The red wine vinaigrette is my favorite. So that's $2.99. Do we want to add on some toppings, some nuts? Maybe, I don't know. There's, croutons there for $1.25 a bag. If we don't want the nuts, which are a little bit more expensive, I think $7.49 is what I'm seeing for the salad topper. I just don't know. Let's go see what else they have. Oh, they have some nuts here. Yeah. Okay, so $7.99 for pine nuts. If I wanted some almonds, it's $4.99. Okay, let's grab the $4.99 bag. That's cool. All right, and then usually what I do with my salads too is I will grab a bag of that Purdue Shortcuts chicken up there. So $4.49. And that's usually just for one salad. So if I'm planning for more than one salad out of my salad mix, I will get more than one bag. Okay, so that's the healthy salad options. Now let's look at some pizza. So, okay, I could get a pizza and heat it up for myself and have that for several days, 2 slices a day for lunch, $6.99. Okay, that could stretch a little ways. Could also get this fresh-out pizza for $3.99. Okay, there's some options. And now let's see here. If we go to this option where they have the wraps and the sandwiches and stuff like that, $5, $6. Okay, there's some options there. Now, what would you choose if money wasn't an option out of those things? There's also these life cuisines, right? 3 for $10, which I promise you, if you go to the store now, they're not 3 for $10, but maybe you just want one to kind of fill in your stuff there, right? Like the carb-wise chicken mozzarella flatbread melt for $5.79. Or there's some of these, healthy choice simply steamers, $4.49. Okay, yeah, there's some power bowls. Those are yummy, $4.99 each. Great. Ooh, but these banquet meals, they are $1.39, $1.79, depending on which flavor I want. I could get more of those. I could get 2 of those for the price of one of the other ones. I have some choices I need to make for lunch, I guess, right? Okay. So just kind of maybe think about which option you would choose if money was an issue, if you're trying to figure out what you want to eat for lunch, because that's the reality. Okay. It has been a long day already. Time to relax. Let's scroll on our phone. Let's go to social media and see what we can find. Start out with some TikTok. No, I'm sorry, Facebook. All that hard work sure has paid off, Britt. Let's go over to Twitter now. This is how much exercise you need to lose 10 pounds. Skinny jeans are for skinny people. Wow, I feel super relaxed now. That was so relaxing. And as an FYI, those were all real screenshots and snips that I took from my actual social media pages. I think I need to start following different people. Okay.
Have you ever wondered how you could rearrange your home to make it more comfortable for your plus size?
Think about the seating in your spaces, in your classrooms, in your work areas. Um, something to think about from earlier when we were talking about that. Like, are there chairs with arms in your office? Are there places that they can access, that folks can access in your office comfortably, safely, and feel like if they go in there for a chat, that they'll actually be welcomed in there? Um, just something to think about. Okay, so again, we're going back to furniture for a minute. In addition to looking at the ladders for when we were moving into our new place, our new place also has a little patio that we can like sit out stuff on. So let's find a new patio set. Oh my gosh, that one's so cute. It matches the vibe I'm going for, and it's on sale. Like, you can't beat that, right? Okay. I don't know if my mouse will show up on here, but there's right here. Table capacity weight is 50 pounds. So don't really set, a lot of heavy stuff on it. And then the chair capacity weight is 250 pounds each. Okay, so maybe I could sit on that, but could I hold my daughter in my arms when I'm doing that? Could a grandpa sit in that and have their grandkids on their lap? Could a giant dog get on your lap while you're sitting in this chair? Maybe not. I don't know. Something to think about. Another thing that's interesting to think about too is I've encountered issues with exercise equipment. Um, just in general, like it either I think this was specifically when I was in physical therapy. And it was for my low back. So they were having me do some like biking. It was uncomfortable because the way that it was set up, and I know that they're adjustable, but not all of them are. It was just constantly like I was kicking myself in the chest with my knees. And just the way that my body is made and the size that I am, it was very uncomfortable to do that. So things that are even supposed to help us lose weight don't always work out for us. And then of course there are, other seating things, which I hinted at earlier, the wonderful airplane that we all love so much. And then theater seating as well. Just, can't always comfortably fit in those, even when the arms do raise up. So that's just kind of a problem. Something else that I have encountered as a person of size, going to parties and gatherings. So once upon a time, in another life, I was a wedding photographer. And this is a common scene that you see at wedding receptions. That looks great and wonderful. There's no people in the seats right now, and I can comfortably walk through there to get where I need to be. And even if I was a guest at the wedding reception, right, like I could make a beeline for the bathroom when I need to. But when people are in those chairs, they are, the chairs are scooted back. It's hard to get through there. And when I was doing wedding photography, it was, oh my gosh, the first dance is happening. I need to get up there right now. And I'd have to navigate and figure out my path. Am I going to go outside the building and go all the way around, which I've had to do before? Am I going to just kind of squeeze through people? And then also those Shivari chairs, which are super popular and everyone loves them. They are gorgeous in photos, but they feel a little flimsy sometimes when you sit on them. I'm not going to lie. And then parties also sometimes have chairs like this, which, number one, the width of the arms, kind of a little difficult to get into. And then also, again, with the flimsy feeling. So that's just, part of what you deal with in life as a larger person. Public spaces. Again, that just goes back to the way that folks view us larger bodied folks a lot. Touched on clothing a little bit, but shoes specifically. Trying to find the widths that you need. Especially if you are trying to be cost conscious about things. You can't always necessarily go to a specialty shop and buy shoes. Maybe you just need a $10 or $15 pair from Walmart, and you got to hope that is going to fit you. Clubs and bars, also problematic. Again, they use a lot of the same seating that we talked about in that the wedding reception area. Not to mention, the wonderful stigma of being out in public. Pregnancy and motherhood, also full of weight stigma. You probably didn't clock it as well, and that's okay. But there was a photo of me at my baby shower for work, actually, in the photos that I showed you earlier. And when you are already overweight and you get pregnant, that's one of the things that the doctors kind of look at a little differently. They treat you a little differently. I was actually not able to have a midwife because of my weight, mostly because of the diabetes, but the weight played into that as well. I was just considered to be too high risk. So I had to not have the birth that I wanted. I had to go with a higher risk doctor. And then just seeking healthcare in general. Am I going to find a doctor who thinks that all of my problems will be solved by losing weight? Will I be able to have the surgery that I need to have? Or will they say, you need to lose 60 pounds first? I'm sorry that, that this particular health issue is causing you problems, but I'm not even going to operate until you lose weight. And then, of course, dating. The wonderful world of dating. I know that's a struggle for everyone, right? And when you are a person of size, it's a little more complicated because, we heard from the opening audio, at least I hope you all were able to hear that, where, it's I'm not going to introduce you to my parents until you lose weight. And, yes, it probably would have been easier for me to make a list of what's not problematic for people of size, because this list is also not all encompassing. This is just some of this, right? All right. So what now? I encourage you to think about what you can do to make your spaces, environments, interactions more accessible, welcoming, friendly, safe for people to use. I know Doctors Caldwell and Slagle will get into it a little bit more, specifically to the dietetics part of things, but just as a person, this is kind of what I ask you to think about is that piece there. So that is all I have for you, and I will hand it over to the folks.
Mute. All right. Thank you, Becca. And so thank you for sort of sharing your lived experience. I think what Lisa and I will sort of dovetail off of that in providing some strategies that we have incorporated within our own practice and mindsets, and based on literature and research that we're both involved with, to sort of impart how might, since many of you in audience are preceptors or dietitians and are just interacting with individuals day to day with various body sizes and backgrounds and experiences. So we wanted to sort of frame, as our title alluded to, we wanted to frame this from a socio-ecological mindset. So we'll define what weight stigma is and discuss factors around what actually impacts weight from a socio-ecological perspective, and explore the limitations of approaching healthcare and health from a measure of weight alone, and then just give you more tangible things that you might be able to incorporate day to day personally, as well as advocating for within the systems that you work with day to day, to hopefully help support more diverse individuals that have the bodies that they have. Okay. So if you're not familiar with the social ecological model, this has been a tested framework, theoretical framework that's been applied to public health and nutrition research interventions. And so it's really positioning, and Becca, her lived experience can emulate this across all of her problematic experiences that she demonstrated. You can see how this would fit into that one lived experience. And so we're all interacting and integrating across different settings. And all of these, what it's really positioning is there's a lot of higher order factors involved in our day-to-day lives that we may or may not have control of. And it's really just showing that intrapersonal, individual level variable is much smaller than larger societal, environmental, and policy factors that may determine somebody's health outcomes, if we're going to kind of focus on one specific piece here, whether that's mental health or physical health. And some similar concepts that you may have heard about related to this are social determinants of health. There's some overlap, or policy, systems, and environmental approaches to thinking about nutrition or public health interventions that may intersect with our clinical, food service, public health, and even private practice care. So diving into some of the specific terminology of what is weight stigma, it's very common, and it occurs across many different sectors. So it can, an individual can experience weight stigma across healthcare, school, from their family members, peers, employment, and media. And we saw some specific examples of this from an individual's experience. And it often individuals become more aware of this in childhood and adolescence, where unfortunately these experiences can kind of sink in just because of our cognitive development, can sort of follow us for the rest of our life. And a lot of the problems that if we're thinking from a social ecological perspective, are from a social and structural standpoint, to rather than putting all of those pressures on an individual. That's one way to think about how weight stigma, having a weight inclusive approach, is thinking that many problems that do exist are coming from structural and social constraints. What is weight bias versus weight stigma? There's some overlap. Weight bias is that term that occurs in many areas of life, such as employment, healthcare, and education, and can be blatant or subtle or explicit or implicit. And the stigma or sizeism is really the larger umbrella term of these two terms that encompasses weight bias and discrimination. And it's really the act of imparting your biases on others, whether that's, again, implicit, explicit, or otherwise. So making assumptions or about motivation or willpower due to weight or body size could be an act of weight stigma. So if you're thinking, hey, I've been taught this my whole life, that BMI means you are obese and that you are unhealthy, that is technically fits within this terminology. And if people can't control that, things that we saw in the social media posts that Becca were sharing, these are all sort of in that lane of weight stigma, where you are imparting this belief that an individual has all of the control in the world to manage their weight, where that is not entirely true. And we'll talk about some of the research behind that. And this is not an uncommon experience, approximately, and this is just some of the research. 42% of adults have reported experiencing some sort of weight stigma. And unlike other forms of stigma, family members, romantic partners are common perpetrators of weight stigma. And this could be in that, if we're thinking about how this looks at the intrapersonal level, this could be at that intrapersonal level of the social ecological model. But if you think about why that might happen, is there may be some larger social factors involved with that. And bias can be externalized and internalized. And so if we see weight bias, and we believe that it's a normal thing without any critical education or thought about this, it's possible that this may become internalized and become self-stigma. So this is termed internalized weight stigma, is the degree to which individuals personally adopt this negative weight-based societal stereotype, and then they judge themselves based on these stereotypes. So we may be unknowingly perpetuating some of this by internalizing some of that without ever being exposed to the ideas that, hey, it's normal to have a different body size, and that's okay. And there's some overlap between our psychological, behavioral, and physiologic outcomes that can result from this internalized weight bias. So we may feel shame, distress, body dissatisfaction from this internalization. And often, and there's a lot of research to back up how these behavioral pathways compensatory pathways can occur from this internalization. So working with clients that may or may not be undergoing dieting through restriction, or binge eating, going more into those disordered eating and eating disorder patterns. And it can just be as simple as having sleep disruption from being stressed and anxious, or even avoiding care, which we don't want to see as a dietitian in practice as well. And also, there's also growing research looking at the basic physiologic response to weight discrimination and bias, and repeated discrimination or internalized bias and anxiety around that may contribute to just our general allostatic load and physiologic load. So just stress, increased cortisol, and the negative detriments of that to our cardiometabolic health. And what we can also see with that is weight internalization does not reliably motivate healthful behaviors. So behavior change, if we're thinking about peer behavior change, motivating folks on a specific number is really what we can see in the research is not fully the true story on helping them maintain healthful behaviors, and is often associated with the disordered eating and eating disorder pathways, and other psychological distress. So as a care provider, definitely reframing from shame in our counseling techniques and recommendations can just to avoid that reinforcing of the diet culture and body surveillance that may be perpetuating this on an individual, just to be a sounding board for them. And so I spoke a little bit about some of the potential healthcare implications here, but stigma does change care. And this is not just with weight, but since we're talking around weight and body size, it can damage trust and patient-provider communication. So if there's general assumptions around weight equals health outcomes, there's already going to be a big wall that can come up between a patient and a provider, limiting patient-centered care. So patients may not want to seek care, or they may avoid follow-up based on bad experiences, or just not feeling like actual problems are being assessed or addressed. And especially when symptoms are just being attributed to weight only, rather than actually using clinical judgment and more objective tools. And provider education does matter, and bias reduction can be helpful within a large healthcare system. We typically, when we're onboarded within a large system, food service, higher education, we're all usually undergoing some bias training. That often doesn't include weight-based bias education and mitigation. It does matter, but also there needs to be broader systems changes when we're thinking about the application of that social ecological model. We can change individuals and educate individuals, but there does need to be sort of a cultural shift, and that often requires some policy and environmental factors as well. And there's a lot of things out of our control that individuals are seeing and interacting with day to day, including media. And we see a lot of examples that we interact with day to day, and Becca showed some that she interacts with day to day that amplify the diet culture messages. And they're often, unless you are able to manipulate your algorithm, we're probably going to come across these, and they often reinforce these pathways of moral hierarchy around food and body size that may perpetuate weight stigma. And a lot of public health research and messaging and media has historically come from this mindset around obesity prevention, and often unintentionally shaming rather than supporting. And weight stigmatizing narratives can reduce the effectiveness of health promotion efforts. And we'll look at some examples of ways that public health organizations are reframing their approach to sort of go against the traditional methods. Diet culture will be used in the context of framing how weight stigma is sort of indoctrinated into our culture. So it's presenting myths about food, eating, and health that lead to longevity health buzzwords, and framing morality around bodies, foods. And this is a very societal and structural level umbrella. So it's at that largest level, if we're thinking about how this looks at the social ecological model, influences a lot of our systems, and obviously the individuals we interact day to day. So just be aware that they are interacting and seeing this and exposed to this, and whether they are influenced to it to a degree or not can be imparted in our assessments and thinking how we approach individuals. And some of the research around sort of the physical implications of weight cycling. So if individuals are exposed to these ideas like, hey, I need to achieve a specific body weight, I'm pressured into feeling this way. We also have research to show that repeated weight loss attempts and regains is associated with increased risks for all-cause mortality, cardiovascular disease, and hypertension. So it's not necessarily benefiting folks to undergo these frequent dieting and possible restriction practices. And we can think of this as relevant to us as dietitians or future dietitians and preceptors, that repeated dieting history could be treated as clinically relevant and not as non-compliance. So this is kind of one of those mindsets that we're hopefully going to kind of bring forward to you, as instead of thinking about individuals, they're just having challenges behaviorally. It's not non-compliance. There's so many other factors that are involved with making consistent behavior changes challenging. And this is sort of bringing in the scope of how we approach a lot of our public health, clinical, and day-to-day work as dietitians, that we've interacted with this medical model based historically on BMI. And in fact, a lot of growing research, and we have a lot of historical research that that BMI scale is limited and should not be treated as a standalone proxy for health. And we're obviously not taught that in practice. And we'll talk about some education strategies that we can think about for imparting other methods and approaches for making more inclusive and holistic assessments rather than just on BMI alone. And often, even if you are aware of eating disorder pathology and disordered eating, just like with this mindset and this topic, health status should not be inferred from appearance and body size alone. And so we have many other factors, and this is kind of why we present this from a social ecological approach or social determinants of health, where body size is influenced by our biology, our environment, access, food access, stress, medication, as well, and not just individual will alone. And was this you, Lisa? I think this is me.
Tag.
Stop sharing.
All right. So this obviously matters a lot to us in dietetics, and healthcare providers and registered dietitians aren't immune to this. And so increasing awareness can help us to provide better assessments, better counseling, as well as support our clients in meaningful goals. The other consideration is that, as Dr. Slagle mentioned, if we know that stigma independently is harmful to health and impacts care, then adding in weight-inclusive care is something that RDs can provide as a way to reduce harm, avoid re-traumatizing clients, help reestablish trust or preserve trust, while all supporting clients in their wellness goals. So there's a lot of conversation out there about weight-inclusive care and some myths about it. And so when we're talking about weight-inclusive care, we mean that care that's patient-centered, centering our clients, being aware that there is stigma out there and clients have had a variety of experiences. And then it's also care that focuses on behaviors and outcomes that go beyond weight and thinking about other things that are going to help support clients in achieving their wellness goals. What weight inclusive care is not, it's not ignoring health. It doesn't mean not providing medical nutrition therapy. It also doesn't mean refusing to discuss weight. So in setting agendas with clients, this means asking permission with clients and determining where weight fits in the conversation. If a client wants it, if it's clinically relevant, how does this align with clients' goals? So, like many of you might be like me, where 20 years ago when I became a dietitian, I definitely had never heard of weight inclusive care or weight neutral care. And so I learned about this as I was practicing and feeling like I needed to fill in some pieces to the puzzle of care I was providing to clients and provide better for my students for their practice options. And so practical starting points for interns, DTRs, RDs are to start taking a look at own assumptions, as well as some of the things that maybe you learned or practice norms that you might have inherited when you came into an organization. Some of the things we can do with clients is consistent with our motivational interviewing approaches is to ask permission before discussing weight and use a client-centered approach in defining what the agenda of the visit is going to look like. And then as Dr. Slagle mentioned, do a good assessment. So thinking about what other symptoms folks are experiencing, what other behaviors are they wanting to try? What is their access to food and healthcare and safe spaces? How does stress impact their health? How does medications impact health? Tell me about sleep, as well as assessing things like experiences with previous diets or changes in weight that they've experienced as well. And then in tracking outcomes, thinking beyond weight. So what are behaviors? Weight isn't a behavior. So what are behaviors that clients want to try that they feel like are attainable, that fit with their life, that we can measure so they know if they've, how that experiment has gone, as well as monitoring other things like labs. Are they eating enough? What other symptoms have they been dealing with, and how have these changed as they've changed aspects, as well as quality of life. So I always think of all the tools that we have as part of our toolbox where we can bring them up in as we see them addressing clients' needs. And so there are a couple behavior-centered models that really operationalize weight-inclusive care. And these include mindful eating and then eating competence, which is an Ellen Satter model. So mindful eating supports awareness and observation of hunger, learning hunger and fullness cues, figuring out what folks like with taste in their food, what pace of eating works for them, and helps them to establish a non-judgmental eating approach in order to improve their experiences with eating and food. Eating competence is a model developed by Ellen Satter, who also developed division of responsibility and some hierarchies, her own food pyramid. And so with eating competence, this is really recognizing that helping folks to recognize that they're experts in their self, and that approaching food with a positive eating attitude, being accepting of all different types of foods and recognizing that people will choose the things that nourish them, as well as learning to trust themselves and being observant of how context fits in with eating patterns. And so one of the things that both these models do is they avoid that kind of I need to control my body to I have a skillful relationship with eating and I'm kind to my body. The other thing is that all these models are like other theories and approaches that we use. They're tools, they're not mandates, and they're something that we can call on as it seems appropriate based on the client's needs. as well as our scope and familiarity with them in assessing what might work best with this client. Okay, so we'll take a look at some of the different care settings and would love to get your impressions and feedback for a couple places that we identified where cognitive dissonance could occur in practice settings. All right, so starting with clinical care, some recommendations. One recommendation is not assuming that weight explains the presenting concern. So what is the client's main goal of this visit? So what do they want help with? Engaging the client in agenda setting is a key component of motivational interviewing. So what is it? Where can we provide support? Also using neutral documentation and language, and we have some more about that on the next slide. Other things to consider are, is weight really needed for the conversation that we are going to have? And then also consider blind weights when appropriate, or reducing emphasis on weight when appropriate. With that, also ensuring and evaluating whether the equipment and seating in our offices accommodates diverse body sizes and mobility needs. So does the scale accommodate diverse body sizes and mobility needs? Does our seating have different options for folks to feel comfortable in the space? And then weight inclusive clinical care would be setting goals around behaviors rather than weight or weight change as the goal. So neutral documentation and language is indicating shifting from judgment and more subjective to including context and care with how we're documenting what the client is reporting. So this looks like describing behaviors, symptoms, and circumstances rather than making judgments about someone's character or their motivation. And also avoiding the moral judgments, that kind of binary piece that can come with food or behaviors like non-compliant or good foods or bad foods, or someone was good this week based on how they ate or what they did, aiming to avoid. Again, not assuming weight explains the concern, acknowledging that there are a variety of factors that influence health, including biology, environment, as well as social factors, and then centering goals on health outcomes that go beyond weight. Okay, so what are some examples of neutral documentation? So one is non-compliant, that term, non-compliance with diet. So one way this could be reframed is difficulty maintaining eating patterns due to work schedule and fatigue. Another one is overeating at night. Maybe someone eats more at night because they hardly ate anything during the day. So a more neutral way to approach this is increased intake in the evening after long gaps between meals. Instead of needing weight loss to improve labs, try nutrition strategies were discussed to support improvement in lipid levels and energy. And instead of using that on or off binary approach, like terms that are failed, so instead of things like failed multiple diets, reframing it as history of repeated dieting and weight cycling. We know that diets don't work. Okay, so I want to check in and do a brief discussion in the chat. So I am also have the chat pulled up. So what do we do? And I'd love to hear thoughts from folks who maybe haven't had this situation, but have some ideas on how they'd approach it. And from those who've had this experience in clinical practice, how have you approached it? So a client comes to you and says, I want to lose 30 pounds. My doctor told me I need to lose weight, and I feel like I've failed every time I try. So some things to consider. What would you do? What would you say first? What would you assess before recommending any plan? How could you support this client without reinforcing shame or a restrict binge cycle? And what outcomes could you offer to track besides pound loss? So take like 30 seconds to a minute, kind of consider either one or all those questions, and how would you respond to this client? Thank you for all the chat ideas. So, lots of affirmations. Thank you for expressing this desire. Could you tell me more? Tell me more about your health goals. It sounds like your doctor has a goal for you. What are your goals? And then linking outcomes to non-weight health goals, which could be changes in cholesterol, changes in energy, changes in functionality and stamina. Try to find specific reasons for wanting to lose weight and maybe shift the goal setting towards behavior and results. Tell me more about your previous things that you've done. What worked for you in the past? What didn't? What strengths? What goals do you have? Maybe track intake of something else. So I know you've been trying to eat more fruits and vegetables. Tell me more about what that looks like. Tell me more about this goal and your interest in weight loss. Validate their experience of not feeling successful at weight and invite them to focus on other markers or other behaviors. You've tried some things in the past and they haven't resonated with you or fit with some of the things that you need in your life. Ask about specific diets they tried and what their thoughts were on why they felt like they failed. Was it too restrictive? Was it too time consuming? Tell me how you feel about your doctor's recommendations. What have you tried? Tell me more about what that means when you use the term failure. What are your overall goals? What else did your doctor mention? Tell me more about that. Sounds like you have a history of trying to lose weight. Can you tell me more about what your experience with weight has been like throughout your life? And that's usually one of the RDs shared. This usually prompts a 10-minute monologue about lifelong diet history, lots of self-shaming language, and there are lots of things to dig into, reframe, and offer tons of empathy for. Also, a desire to know more about dynamics with family, what they eat, what their values and priorities are with life. And thank them for sharing their experiences. Yeah, so affirmations are huge. Asking permission to share additional information or maybe offer different approaches that they might not have heard before. And doing good assessment with some of the things that they mentioned about their health history, things that work for them and their life, and offering to track outcomes to determine how their different behavioral experiments go, to see what works for them. Well, thank you so much, everyone. Okay, so we talked about clinical care, and there are some recommendations within community and public health nutrition. Certainly, none of our bullet points are the only things, but just a start to get us thinking about some options. So one, as Dr. Slagle mentioned, is avoiding fear-based or shame-based messaging. Sometimes this looks like you should or you will. As well as using inclusive images and asset-based languages. So maybe what our bodies can do, as well as images that demonstrate a wide range of bodies doing a wide range of things. The Rudd Center has some great images that can be used that were specifically designed to address weight stigma. Also, all of us who've worked in community public health know that we can't talk about nutrition without thinking about food access, safe water, affordability, and all the other social context and environmental factors that play into what life looks like. In thinking about public health as well, sometimes we might be using campaigns that have been designed in the past for a specific audience. And so looking at, as we think about what campaigns we might be interesting to adopt or adapting to our communities, to look at them through a lens of assessing, is this perpetuating stigma? And then in our education pieces, adopting frameworks that are weight neutral and evidence-based eating, for example, division of responsibility in feeding when working with parents of young children. And then again, assuring that the spaces are welcoming and accommodate diverse body sizes, abilities, and also the people that folks are bringing with them in environments and spaces. Within food service, some opportunities could be removing moralizing language from menus and wellness materials and using a weight-inclusive food neutral lens to promote nutrition. So that might look like not categorizing foods as good or bad, or folks are good or bad for eating certain types of foods. And thinking about how things like accessibility, sustainability, adequacy, and also balance can be incorporated. And then ensuring that the physical environments and spaces, again, have room for folks to move between seating and have different seating options to allow folks to move around and access food and the food choices that they want to make. Okay. All right, so for us educators and preceptors. Hi, y'all. So there are some great papers out there. Dr. Slagle and colleagues have a couple that were recently published. And so there are a number of additional things within those resources, but calling out some top three would be shifting learning outcomes beyond weight. So helping students to understand behaviors, symptoms, labs, and quality of life factors that we can support clients with, again, that go beyond just weight, as well as be explicit in our conversations that BMI is problematic and how it's used and how it should not be used. We can also use inclusive case-based and applied learning where weight changes is not the goal, weight is not the presenting problem, and support students in practicing that documentation that shifts from more judgment subjective tone to neutral and context-based language. And then really aim for supporting students in developing the art and the science that we know so well within dietetics. So supporting effective counseling, counseling confidence in effective counseling strategies as well as skill, not just knowledge. So asking permission before bringing up any topic, including weight, motivational interviewing skills, reflective listening, open-ended questions, affirmations, really avoiding shame-based or fear-based messaging, and then helping to support client or students in recognizing that just knowing the technical pieces of nutrition is incomplete without some of those relational skills, client-centered skills, as well as self-awareness of some of their own prior experiences and preferences as they go into supporting clients. Okay, one more activity for y'all to go into the chat. So another area where folks may be experiencing some cognitive dissonance when you're like, I just went to this presentation, but this doesn't match what's happening in my organization. So okay, this scenario. Your clinic team evaluates nutrition counseling effectiveness by percent weight loss at follow-up. So I'd love to hear from all of you. What are some risks that you see as using this as an outcome? What are some alternative indicators? And most importantly, I think sometimes in the hardest thing, how might you bring this up to your team, or how have you brought this up to your team if you've seen practices within your organization that were perpetuating some stigma? So I'll give us like 30 seconds to a minute to see what you come up with, and I'll watch the chat. All right. So we know this doesn't tell the whole story. And it really is limiting in our assessment of clients' health as well as effectiveness of nutrition education. Measuring quality of life could be an alternative approach. There are validated questionnaires for that. There might be fluid retention, and that so this measure is not valid for understanding health. Percent weight loss also could indicate negative health outcomes as well. Indicate additional restriction or inappropriate approaches being used. It doesn't tell the whole story. Muscle mass and hydration status aren't considered in that. The client ideally is engaging in resistance exercise, which will impact other factors. Praising consistency of behavior change, so celebrating behavior changes that clients meet. This isn't represented in percent weight loss. It may not be an effective outcome depending on where we look at stages of change either. So if they're in contemplation and moving to preparation, that is a change that we don't see reflected in this. So we miss a lot of things when we just focus on one measure, like weight. It also may unintentionally reward things that aren't helpful for wellness. We talked about some alternate indicators. And so some options for raising this concern: provide colleagues with links to research and webinars to help them learn, and expanding appropriate nutrition counseling effectiveness. Also, what are other things we can measure and how can we make sure that's included in our dashboards or represented through surveys that we are collecting with our clients? All right. So thanks y'all for all your ideas and participation. I will keep looking at the chat so we can continue the conversation as Brianna and Emily take over. But we've been so happy to share some opportunities for change across the socio-ecological model, from individual to systems, in looking at bias awareness, self-reflection, as well as language we are using, interpersonal level, kind of avoiding comments about body sizes, shapes, changes, looks, avoiding food morality, and engaging in respectful client-centered counseling. From an institutional level, having body-inclusive spaces, assessments that collect the right type of information and that don't perpetuate stigma. And then from policy and systems, gosh, we could probably do a whole other day of conversation about this. But, taking a look at reimbursement systems, as well as training that's available for healthcare providers in order to support us in not just changing individual ideas, but aiming to change environments and systems. Brianna, we have in your slides that you'll get from Brianna, we have some additional resources, but I know that we are getting close to time switching, so we'll stop there.
Thank you, Lisa. Does anyone have questions for Becca, Nick, or Lisa? You're welcome to type them into the chat or unmute yourself. And if you have questions that are coming up as we move forward, you can type them in the chat. And if Lisa, Nick, and Becca have to log off, I can maybe get those questions answered and back to you. Doesn't look like anyone is going for that unmute button. So we will then move forward. Thank you so much, you three, for sharing this important information. We are so grateful for your time today. So please hang tight. We've got some more content to cover. And let's move right along. So let me get my presentation up. The next section is going to cover information pertaining to updates within UNC's program, but also within dietetics education as a whole. So a couple of things that I wanted to share here. So First off, I'd like to express gratitude for our current, former, and future educators, particularly our preceptors, because we cannot function as an internship without you. So whether you are a preceptor for UNC or for another program, thank you for your service to our profession. As someone who precepting is not part of my current job functions or a requirement of my job, I recognize both the rewards and also the challenges that come from taking on interns. And so I can say from personal experience, thank you. Your efforts are not going unnoticed. So April is Preceptor Month, and we've been spotlighting some of our extraordinary preceptors on our social media pages. If you'd like to see those, I'll have QR codes later in the presentation. And you can also search UNCO Nutrition and Dietetics to find us. One recognition that UNC provides is Preceptor of the Year. Each year, we look at individuals who have played a significant role in our program, preceptors who either graciously host multiple interns per year, or maybe who host one or just a couple of interns per year, but for an extended period. What we do is we take a look at the information provided from the interns' feedback, interactions that preceptor had with UNC faculty and staff, and we use all of that to help us make a decision on who to award this honor. All of our preceptors are eligible regardless of location, rotation, length of time that you've been a preceptor. I will say that preference is usually given to individuals who've been precepting with us for longer, largely because we've had more of an opportunity to interact with you all and get to know you, leading to that nomination. Preceptor of the Year gets a gift from us and nominated for the Outstanding Preceptor Award through the AND. Our first year doing this, our nominee Gina O'Brien was chosen for the Academy for the Outstanding Preceptor Award. She received a stipend to go to Fancy, recognition through the Academy, and it was all very exciting. So without further ado, we're delighted to congratulate the 2025 Preceptor of the Year, Laura Hedges, clinical RDN with UC Health. And more importantly, to thank Laura and to thank the UC Health team for your work, dedication to UNC, and just to our next generation of RDNs. If you personally are interested in either nominating yourself or a colleague for this award, please reach out to us. We only have the information that we have from interns, from our interactions with you, and we know that there's a lot that goes on that we don't know about. So don't ever hesitate to reach out and give your colleague a pat on the back in that way. Kind of on the similar topic, I'm just going to take a minute to discuss the common benefits that we hear when it comes to precepting and to share some satisfaction info. As you may know, internships across the nation are struggling to maintain professionals in the field who have the capacity and the desire to host interns. If you are not already one of our preceptors, please consider becoming one. You can express interest by typing into the chat. You can email me personally, or you can email our DI email listed on the screen. And here are some of the reasons we found that preceptors feel that precepting is a benefit to them. So you can view this as a long interview or even a training program, perhaps. Many interns apply to our program because they wish to remain in that geographic location, meaning that they aren't relocating for rotations and then going back home afterwards. They're usually staying right there and seeking employment. So many of our interns seek employment at their rotation sites. I was hired right out of my internship, and I think my former boss would say that having done that internship allowed that training period to go more smoothly. I was very familiar with the hospital. I wasn't getting lost anymore on the 15 floors that we had. And we recognize that organizations that employ dietitians, especially right now, especially in healthcare, government-funded programs, we recognize the struggle and the pains of being understaffed. We see that is felt. So our hope is that by hosting interns, you can benefit from that as much as they benefit from the experience. Similarly, much of the interns' work is related to operational support. If you haven't had the time to update the menu cycle, redesign educations, examine the budget, these are all projects that the intern can do. And they're also required to complete staff relief for both clinical and for food service. So allowing you to shift your focus to different projects that you maybe have not had the opportunity to do. You also receive CPEUs just for precepting. The Academy also provides a free CPE program for preceptors that grants 8 CPEs upon completion, not to mention that we host free CPEs such as this one once or twice a year. Everyone really is invited to attend, but if you're a preceptor on our list, you'll receive a personal notification of that. And then since UNC was the first distance program established, we have a long history of fine-tuning our program, resulting in a 97% satisfaction rate from the preceptors who've completed our evaluation. So yes, every piece of feedback we do read, and we aim to evolve along with the evolving landscape of education and dietetics. So thank you to those of you who've completed any evaluations and shared your feedback. Of course, you have this unique opportunity to help shape the next generation of RDNs. Not to mention, this can help strengthen your leadership, your professional career, strengthen your resume. I always learn from my interns. I find it extremely fulfilling, rewarding, and a learning opportunity. And I see comments in the chat. Thank you, Brooke. We love having you as a preceptor for UNC too, and so grateful that you have enjoyed your experience. So if you're interested in precepting, please do let us know, or if you have any colleagues who might be interested. Geographic areas in which interns will be needing rotations in the coming years include LA and Fresno, California, Idaho, Dallas and Austin, Texas, New Hampshire, and North Carolina. These are specifically areas in which we have fewer connections, and so we'd appreciate any and all assistance there. Now, to keep you just informed about the program, some reminders and updates here before I turn it over to Dr. Boldrin. The DI standalone is largely unchanged, with the exception of now all applicants must possess or be in the process of completing a graduate degree per the 2024 change. So we are always making updates to processes such as how we have you score competencies and complete progress reports, that kind of thing. But from your standpoint, there isn't anything largely different in terms of the program itself. Regarding the application process for the DI, that is also similar. So DI standalones, those are the applicants coming for our internship without the MS attached. They will be seeking rotation sites before they even apply to our DI. Whereas the MS DIs, they have already been accepted into our program, and they're in the process of doing the MS portion of that. And then they'll be starting to secure preceptors once they're already accepted. So regardless of which program they're in, we really put the onus on the intern to have most of the communication with the preceptor. But often we'll step in if we're finding that, an intern is having difficulty obtaining rotations, or if preceptors want to speak to us instead of the interns and the applicants, we're always here to help support in that way. So we sometimes don't even know who the DIs are that are applying to our program, whereas the MSDIs we've already interviewed and they're already accepted into our program. As of 2025, we've adjusted our program to be more cost effective for all students and also to offer an extended or in a condensed timeline. So now we have a 2-year expedited program, and we still have a 3-year track. And we've reduced the total number of credits for both just because we recognize how cost prohibitive this pursuit can be. But what that means for you all is that the MSDI students who've opted for that 2-year track, in that second year, they're both taking coursework as well as completing supervised practice rotations. We have made them aware that that second year will be rigorous simply due to that combination of courses plus rotations. And we've asked them to put a plan in place to focus their efforts on school. Many of our interns and students do work and have families that they're caring for and whatnot. So we've explained to them the expectation of what that second year is going to look like in terms of how rigorous we anticipate that it'll be. But that's where I'm going to leave things, and I'm going to allow our director, Dr. Emily Boldrin, to take over and share some updates from Ascend.
Okay, thank you, Brianna. Let me see if I can share my screen appropriately. Okay, let me do the presenter view. All right.
So it looks like we're seeing not the presenter view, but the opposite view.
That better?
Yes.
Okay. All right. Well, thank you for all you that are here. We're very grateful that you're here. I know a lot of you are preceptors, maybe for our program, maybe not. But we wanted to talk about some big changes that are coming in 2027 from Ascend. And this will impact you if you are precepting interns, whether it be from a coordinated program, graduate program, or a standalone DI. But before I go any further, just thank you to Brianna for organizing this presentation. She did all the legwork on this, and we're really grateful that you put this together. So let's get started. I know policy and procedure is sometimes not very fun to talk about, but as I mentioned, these are fairly large changes, so we wanted to make sure you were aware of it as you're going into precepting. Probably fall of 2027 when you'll see these changes start to take place. And when I'm talking about the standards specifically, um, know that these are the like minutia of the standards are still under review. So think of it as a framework. You may see it a little bit differently when it actually comes out. So before we begin, I recognize there may be people here that are unfamiliar with Ascend. So I just wanted to do a baseline foundation knowledge of kind of what we're talking about. So Ascend is basically the accrediting body of any dietetics education program. And what they do is they set the standards of what dietetic education programs need to provide to students. And they accredit all the programs, dietetic programs, the NDTR, the DPD, with the standalone DI. There's a coordinated program that can be bachelor's or graduate. And then there's also a graduate program. And you may see that referred to as an FEM or future education model. And Ascend works separately than the Academy of Nutrition and Dietetics. They make it very clear that they are separate entities, and so their mission is really singular, is to ensure the quality of nutrition and dietetics to advance the practice of the profession. You can see also their vision, values, and strategic goals. They update their education and curriculum standards every 5 years. So our next update to the Ascend standards will be implemented in 2027. They have released those standards for public review, and I'll talk about that already, but they won't be in place until 2027. So what does this standards process looks like? So Ascend really takes great pains to really collect feedback from a lot of different stakeholders to establish those standards. So we have DPD, DI, CP, and GP faculty under the Expanded Standards Committee. Also NDTR, they gather student members, RDN practitioners, and public members. So that's the Expanded Standards Committee. And then they have a subgroup that is specifically for those NDTR programs, which include NDTR faculty and practitioners, RDN faculty and practitioners, and public members. So they're really trying to get a wide variety of experiences and feedback in order to create these standards. And how is the feedback gathered? So like I mentioned, the standards committee, as a lot of different people, they look at those standards and work and say, where is the profession headed? Where do we need it to expand? And what are the challenges that we're facing? And they put together these proposed standards, and then they present it to Ascend, and then Ascend presents it to the public. So you won't see it on their website right now because the public comment period has passed and they're working to revise the standards. But they released them to the public earlier this year, and they provided a timeline of when that feedback could be provided. And so they try to get it from various people, program directors like myself and other people here. They are asked for their input. They present a lot of different town halls and presentations, and they talk about it during conferences to really get the feedback that they need to get those standards where we want them to be, and then they want them to be as well. So let's take a look. This is, again, a very brief overview of the standards for 2027. So just a kind of brief overview. The Ascend standards, part of what they do is they establish what has been known as the KRDNs for DPD programs and CRDNs for DIs and graduate coordinated programs. And those are really the learning objectives. What does a student need to learn from this program? What does the intern need to learn from their experience and their program? This is one of the biggest changes in the 2027 standards. We are no longer going to have the KRDNs and the CRDNs. We are transitioning, or Ascend is transitioning into what they call competency-based education. And so that means CRDNs and KRDNs will now be referred to as competencies. And I'll go over that in more detail later. And that competency really aligns with the competency-based education model. So that's why they're moving towards that language, because it aligns with the model. So the focus is building a continuum of education throughout the different program types where the students build on their knowledge instead of repeating their knowledge. And I have a slide that demonstrates what that means. So these are the different types of programs. We have the associates, which is the NDTR, the bachelor's, which is associated with the DPD, and then we have the DI, or supervised practice, which is what they're now going to be calling it, and then the coordinated program. That includes the coordinated and the graduate. So starting in 2027, graduate programs are FEMs, and coordinated programs will be lumped together as the same. But I want to draw your attention to that kind of stacking of competencies. So you see here that we have years 1 and 2, years 3 and 4, and years 5 and 6. So it really is focusing on, okay, years 1 and 2, this is what you need to know. Years 3 and 4, here's what you need to know. And years 5 and 6, that's the practice part. And what you need to know and be able to do is a little bit different. So this is a little bit more detail in here. So In the associates or the NDTR, the competencies for the first 2 years, they're focused on things like sciences, electives, general nutrition, and then we go up a little bit in difficulty and critical thinking and knowledge. So in years 3 and 4, we move to the DPD competencies, which is those organic chem, biochem, metabolism, MNT, food science, those types of things. And then in years 5 and 6, we're really upping the standard even more. We're doing the supervised practice or the internship, the graduate level academic work, epidemiology, research, those types of things. So that is just a brief overview. I'm going to go into those standards a little bit more, but they are a little bit complicated. So before I go into that, I want to highlight some of those new standards that we're looking at. So, program completion requirements. So this is going to be a major change. If you are talking with students about becoming a dietitian or you're working with undergrads, this is something really to be aware of. So as you know, a couple of years ago, Ascend moved to the master's requirement. And they said in that any master's will work. So as a program, we have students with masters from all different areas, whether it be an MBA or theology, whatever it is, that still qualifies them to sit for the exam because they have a master's degree. And if they've met all the other requirements. But in the new 2027 standards, that looks a little bit different because those competencies are now stacked. So those years 1 and 2, 3 and 4, and 5 and 6, they are saying that the graduate degree must be in a major course of study in human nutrition, food and nutrition, dietetics, public health, food systems, etc. There's a complicated process for current masters in nutrition programs that aren't Ascend accredited that we'll need to go through. But just as a general guideline, that is something students will need to be looking out for in the near future. That implementation will probably not be in 2027. They are going to, it sounds like, give students a time to kind of adjust to that new requirement. But again, just something to be aware of. The CDR eligibility will not change. CDR will still say you have to have a master's degree. It's not going to specify in human nutrition or anything like that. But it's those competencies. They have to meet those competencies at that graduate level, which is kind of the determining factor. That curriculum stacking, from a sense point of view, is designed to save students time and money. One other big change, which has been hotly debated. So again, this might tweak a little bit, but the new education requirements for the program director. So previously, program directors, if they are doing a graduate program, like a coordinated program or a FEMGP, they just needed to have a master's degree. Now they are saying because a master's is required, then that program director needs to have a terminal degree. So we'll see how that shakes out. They have 10 years to meet that requirement if they are already in that position. If they are hiring new, then they will need to hire somebody with a terminal degree. Again, hotly debated. There may be changes in that. But if you notice as a preceptor some shakeups in organization and personnel, that may be why, so something to be aware of. Program length is also a change to the DI and the coordinated programs. So previously we were allowed 700, or I'm sorry, only 700 hours were required in a professional setting. So 300 hours could be alternative learning or remote. They are now upping that to 800. So there's a little bit less flexibility for those remote rotations, which have been really nice for students wanting specific experiences. So we'll just have to adapt to that. They are also highly encouraging prior assessment of learning. UNC already does that. We have quite a handful of students who have prior experience, and we do assess that for counting for internship hours. But you might see more of that as well, again, because their emphasis is on we don't want the student to repeat experiences. We want them to have that streamlined. Another Another change is the high acuity clinical setting. Previously, there wasn't any specific guideline in terms of our requirement, but now they're saying the majority of your clinical hours as an intern has to be in a high acuity clinical setting. So obviously, this is a big change for program directors and for preceptors. We might come begging and pleading for more hours if you're a clinical dietitian in an acute care setting. And just know that that's where it's coming from, not specifically the program. And then they outlined specific rotations that programs must have clinical community and food service rotations. All right, so now we're going to get back into that curriculum, the competencies and performance indicators. And this, it is a little bit confusing, but I think the more you hear about it, I think the more and more it will become clear. And if you're a preceptor for our program, we will provide training on this, so you're not kind of left out in the cold trying to figure out how you evaluate these interns. So the competency-based education model, it is basically three levels. Level one is the unit, and I have a picture that will make that a little bit more clear on the next slide. So they're broad, the units are broad, they describe a group of competencies and a focus area. And then let the level two are the competencies. So the competencies identify expected performance, knowledge, skill, and judgment. And then the level three is the performance indicators. They define the competency or the level of expected performance. And how I look at it is the performance indicators really tell you how you're going to meet a competency. So let's look at that, how that looks. So, you can see, so this is the like curriculum map kind of that Ascend gives us. So that's where this is coming from. It probably will look different for the evaluation. We'll try to make it a little bit more streamlined, but just so you can see what it's talking about. So here's the Unit 2, Nutrition Care Process and MNT. Here's the competency, the 2.1. So the competency always has two numbers. The performance indicators always have three numbers. So 2.1.1. And then this is new. They also identified where these competencies and performance indicators, where they are going to be met. So are they going to be met in the academic unit, or are they going to be met in supervised practice or the internship? So it's very clearly delineated, which is great for the program, so we know that we're meeting expectations. And then this little letter right here is what is the expected performance level. So D stands for does, S stands for shows, and K stands for knows. K isn't on here, but the next slide will kind of show you what that means. So the competency-based education model, Ascend used the Miller's Pyramid to kind of adapt the competency-based education model for the programs. So it is again, a building, a stacking of skills and competence throughout that 6-year program. So that you start at the nose. So the fact recall, studying for an exam, just kind of like rote memorization. The shows is okay, a little bit higher than the nose level, and it's a really demonstration of learning. And you can see in the shows, it's towing the line between practice and didactic. And it really is what I think about it when I'm working with an intern in supervised practice. I think of it as you can do it, you can demonstrate you're doing it, but you still need assistance in that skill or activity. And the does is you can perform it. You are doing like the NFPE by yourself. You're really rocking it. And so you'll notice after those performance indicators and even after those competencies, it tells you what, this is a skill, but where are you expected to be able to perform it at? What level? A no shows or does. And that will help you when evaluating the intern. You'll be able to see, okay, they're supposed to be able to do this independently, and you can evaluate it that way. All right, let's keep going. Okay, so the DI specifically, which is what we are, a dietetic internship, we are responsible for 18 supervised practice or internship competencies. The academic unit, the MS, is responsible for 8. So they are simultaneously in some cases, if they're on the expedited track, learning in tandem. They're getting those competencies in the MS and then also the competencies in the DI. If they're separate, our traditional track, they're getting those competencies then before they move into the supervised practice. There's a total of 26 competencies, and you can see here are the units below. So not only are we changing the language, so no CRDNs, no KRDNs, but we're moving to competencies. If you've been a preceptor for a while, you know that Ascend likes to add competencies and push students and programs to expand their scope of practice. So this year is no exception. There are expanded competencies. And you can see them here. There are new clinical skills, injections, swallow assessment, imaging, and genetics. You can see that all of them, but the swallow assessment are first being introduced in the academic unit. So our program is working to figure out how we're going to do this. We're going to hopefully partner with other programs within the college who do these things, nursing, SLP, those types of things. But just be aware that this is coming. I don't anticipate changes in these expanded competencies. Ascend has been really assertive that we need, as programs, as educators, we need to expand our scope. And so you can see kind of what the future holds in terms of these expanded competencies. All right, and that's it for my presentation. Thank you, guys.
Okay, thank you, Dr. Bolden, and thank you everyone for hanging with us. We've just got a little bit more to cover. So I wanted to share these also with you, and I'll send them in the chat too. If you're here live, they'll also be on the PDF if you are viewing this later. And these are the direct links to our website pages. We just went through a major website change, so things look a little bit different now. We've created a page specifically for our preceptors, and that's that first link there. If you have ideas or suggestions, things that you would like to see on this page, let us know. Right now, there are a couple of videos, some documents that you can download, and some just overview of information. We wanted to toe the line between giving you the information you need and having it be overwhelming. So if you have feedback about that or really about anything, we're here to listen. The next two links are the links to our post-baccalaureate programs that will have interns, so the DI standalone and the MSDI. So that way, if you're wanting to explore more about what the program entails and the application requirements are, if you're getting requests, if you're a preceptor getting requests for rotations, please take a look at those. We also have a YouTube page where this video will be posted. We house our past CEs there, our open houses, and some just general overview videos. And so the link is there as well. And then the very last one is a link to our master's program. So we have a 100% online master's degree that is designed for either DPD grads or RDNs or both. And that is a 2-year online program, no summer courses, and it's very doable for our folks who are working full time. That's kind of how it's been designed. If you are interested, the AND also generally provides pretty substantial scholarships when it comes to the, achieving education like this, specifically for RDNs pursuing a master's degree. I think this year it was about 20,000 that you could apply for, which is quite substantial. Of course, they update that on a yearly basis. So just a couple of other things. If it hasn't been stressed enough already, we want to assure you that the way that we approach our education for our interns is multifaceted and is not entirely on you. And what I mean by that is that we deliver educations, readings, projects, case studies, that kind of thing for our interns to review. And if you are concerned about the knowledge that they have coming in or their progress through the rotation, please don't hesitate to make us aware so that we can address any knowledge gaps on our end too. This is, a team involvement, and just because you are their preceptor doesn't mean that we expect that to be all on you. I also wanted to touch on the new competencies that had been rolled out in the past, new competency rollout, and also the ones that Dr. Bolden just addressed as coming to what we expect to come in 2027. We have originally, when those came out, when we saw the NG tube placement, the swallow eval, there was some concern that arose, amongst us and amongst our preceptors. And so we just want to reiterate that we recognize, and the individuals on the board who've created these competencies recognize, that many currently practicing RDNs are not placing NG tubes or giving injections or performing indirect calorimetry. But the process here is that we're thinking about future dietitians too. So the hope is that if you have the capacity at your facility to place an intern with someone who performs those functions, whether it's a nurse, an SLP, a respiratory therapist, at least for them to gain exposure, that will set them up better for success if they have the opportunity to do that in their career. And I'll share a personal experience in kind of a similar regard. When I was performing my thesis, my project included a blood sample analysis, and the plan was for me to work with some other students, and they would be drawing blood and analyzing it. But due to some unexpected turns in my project, I had the opportunity to do my project entirely independently. And thankfully, I had gotten a brief overview on phlebotomy training before all of that. Something that I never thought that I would do, but then ultimately had the opportunity to do. And because I had that initial training, it allowed me to feel more comfortable when I was, refreshed on the processes and actually doing something that I never thought that I would do as a dietitian. Phlebotomy is not on the list of competencies, from what I understand, but we recognize that placing NG tubes and giving injections and those kinds of things might feel similarly. And so I just wanted to share why the board wants interns to gain exposure. We don't expect them to be experts by any means, but providing exposure now leads to better success in the future. So thank you for your attention and your patience with all of that as we better prepare our interns for success. So we have a few minutes, and I'd love to open up the floor if there are any additional or any questions or comments that have come up that anyone would like us to address in the next few minutes. You're welcome to raise your hand in the feature. You can unmute or you can type in the chat. Okay, I'm not seeing anything, but if anybody has something to share, please just go ahead and interrupt me. So in closing, couple of things. I sent a survey in the chat. It includes questions that we are meant to be asking you regarding the CPE in your experience. If you're interested in precepting or if you're interested in presenting for a future CE, you're welcome to email myself or the dietetic internship email. And then these are our social media QR codes. We've got our preceptor spotlights happening this month. And so we'd like to thank you for your attention today. And let me just make sure there aren't any last minute questions. If you, I miss you too, Linda. Thanks for joining. If you email myself or Taylor or any contact that you have here, we'll send you that CPE certificate for those of you attending live. So that you can keep that on your records. And I will also send those links in the chat before we log off here so you can snag those, but pretty easy to search for us if you need us. So we'll hang out here for a bit, but for those of you who don't have any questions, thanks for joining. We so appreciate you.